But the x-rays are done to help give us more information and to correlate the patient's clinical picture. So you wouldn't just do a diagnosis based on the x-ray alone. Just like you wouldn't do a diagnosis solely based on a clinical assessment alone. You're going to get the labs, you're going to get the x-rays, you might get PFTs, right? All of these are going to kind of go together to help us make a good, accurate diagnosis and treatment plan. So the objectives for this lecture are to recognize the correlations between what you see as far as your clinical picture and your assessment of your patients to what you see on the imaging. We're going to talk about 4 densities on the x-ray, so you should know what those are. And we're also going to review some of the different positions that they'll put patients in to take x-rays, and you should kind of understand why you might use those, why there's different positions and how that can be beneficial depending on what you are wanting to see. We're going to spend a good bit of time on what makes a good x-ray from a bad x-ray. Is this a good quality x-ray? Because if it's not a good quality, then you're going to have very limited accuracy of however you are going to explain what's going on there. You may not see what you need to see. You may see things that aren't there because it's artifact. You may not be able to see much of anything. So we're going to talk about that. And then we're going to talk about the basic anatomy on a chest film. I want you to star, highlight, write it on a sticky note, whatever, because you will have to do that on the test. And I'll show you the slide that you can study for that. And then we're going to go over what these different kinds of pathologies look like on an x-ray. And you should be able to identify many of them. I'm going to talk about some key findings for you to look for to be able to distinguish these. And then the last thing we're going to go over is what some of the common artifacts are, like NG tube. Well, how do you see that that's what that is on an x-ray? CVP line, chest tubes, things like that. Okay. But we're going to try to take it kind of nice and slow. And I just saw that I go from 6 to 8 to 9, so pardon the numbers there. At the very end, we're going to compare other types of imaging. So the majority of this lecture is on chest x-rays, because that's what you'll most commonly see. But we will look at some CT scans and MRIs, and then we're going to kind of just briefly review these so that you recognize what they are and kind of just have a working understanding of what kind of information you can get from them, because you will see them referred to in patients' charts. So the first picture we have here is kind of how an x-ray is generated. And I guess I want to say too, I am not a radiologist. I don't expect you to be radiologists to be able to diagnose everything. It's just kind of getting a working understanding of what you can glean from an x-ray, even at this stage, okay? You'll do more with x-rays throughout the program as you build on your knowledge. And because of that, you'll take whatever little bit you get from this, you'll build upon it whenever you have Chase's class. You'll build upon it in your senior year, hopefully with your patient case management classes as well. And when you're in clinical, ask if you have any downtime, which you probably will, ask if this patient has an x-ray to get your preceptor to pull it up for you, show you how to get to it in Epic, and look at it and read the interpretation, because that will help you in becoming better at recognizing things. So the first thing we have is we have a transformer. Something is generating what becomes the x-rays, okay? It's usually an electrical current that is generated that comes through these focusing plates, and it makes this cathode stream that's going to hit an anode that then kind of creates the x-ray that penetrates through the patient. You see there's a window here, and then it penetrates through. Now the patient has somewhere, either in front, behind, or on the side, there's a film cassette. That's what's capturing the image that's coming from the x-ray. What happens with these x-ray beams when they go through the body? That's kind of a general question. Either they get absorbed or they pass through, okay? So that's kind of how the x-ray works, its ability to penetrate through tissues. So the amount of penetration that we have determines what we see on the x-ray. And what determines the amount of penetration is how thick the tissue or the substances are. So for example, bone is very dense, okay? So bone is going to absorb those x-rays, and not many is going to pass through. Whereas a lung that's full of air, there's really nothing there to absorb it. Those x-rays will penetrate right through to that cassette. And that's what gives us the difference in those colors. We're gonna see when we talk about densities, those things go from black to white and a bazillion shades in between. And all that is based on the absorption of those x-rays coming from the machine. When something absorbs the x-rays, and like bone, we call that radiopaque, right? And you're gonna recognize that they'll be white on the x-ray. Because it allows less to actually go through to the cassette. But when something is low density, like air, we're gonna call that radiolucent, because more will penetrate through that to the cassette. So we have radiopaque, such as bone, that's gonna absorb all that x-ray and less will penetrate through. And then we have radiolucent, which absorbs less and more passes through to your cassette. One thing that's important is that from where the x-rays are coming from to the patient, that distance is important to the image that we see. So it's recommended that this film cassette should be at least 6 feet from where the x-rays are being generated. So this distance from where it hits this anode and the x-ray beams are projected to this film cassette is 6 feet or more is recommended. Whenever you have a shorter distance, it can start to distort some of the images, and I'm going to show you some examples of that. Okay. Some reasons that we're going to do chest x-rays is to, we have this physical assessment, and we want to see what's going on to create some of these things that we're seeing, hearing, and feeling. So we want to detect what alterations are occurring. It'll help us in diagnosing whatever disease we may be dealing with, a pathologic process. It can also help us in determining the appropriate therapy to use. If we do an x-ray and we see pneumonia, then we know, okay, we need to probably give a broad spectrum antibiotic. Whereas if we see an x-ray and we see something that looks more like a tumor, then we're gonna have to do some other testing to see what kind of tumor that is and how we should proceed. We see a patient that has hyperinflation, okay, we're confirming this is chronic lung disease, we're gonna treat that differently than the other two. So we can also use it likewise to evaluate our treatment. We can determine if the position of the tubes and catheters that we have placed are in the right place. And that's always a good thing anytime you do anything invasively, to make sure that you got your catheter where you wanted it and didn't cause any puncture or damage to the lung during insertion. Observe the progression of lung disease. And I like to also think the improvement of lung disease if it's a reversible condition. Bless you. And also assess the patient after an invasive procedure, whether it was inserting a tube or doing something else, to take that x-ray to make sure that nothing was left in there, that everything is held, whatever the case may be, is always a good idea as well. You will often get a chest x-ray when we talk about intubating, which will be at the end of spring semester. We'll be doing that in lab. One of the things, we have our little tests that we do at the bedside, but then the last thing we say is get a chest x-ray. We want to make sure that the endotracheal tube is positioned properly in the trachea. It's not too high, and it's not too low that it's gone into the right main stem. So that's one thing to say, get an x-ray to check the placement of that tube. So here's the densities that I mentioned. There's 4 of them. These are in order from the most dense to the least dense. You see bone is first. Remember, bone is going to absorb those x-rays and let very little pass through them. So they will appear white. So on this picture here, you see the clavicles and you can see the ribs. Now these ribs that you see, these are the posterior ribs. Okay, so please remember that. We're going to talk about how you can find and see the anterior ribs, but these are the posterior ribs. Then the next dense down from bone is water. It's less dense, still kind of dense, but less dense than bone. And then we have fat, and it's actually mildly radiolucent. So it's not quite as radiolucent as air, which appears as black on the x-ray, but fat is just another step up. And then all of the organs. So you can see we have the diaphragm, you might even see the stomach. If you get an x-ray of more abdomen and less chest, you'll see different organs there. They will have varying densities. So they will have varying shades of white, black, gray, and it all depends on how thick or thin they are. If you have an organ that has a thinner portion, that's going to allow more x-rays to pass through, so it'll appear lighter in color. Whereas if you have a portion that's really dense, it'll let less x-ray pass through, it'll appear more white, okay? So it's all about how thick the tissue or organs are. Now sometimes, I think there's even one in this lecture, every now and then you might see a reverse contrast or reverse image where it's kind of mind-blowing at first. It's like, wait, what am I looking at? The bones, things that are more radiopaque will be black, and the air and things that are radiolucent will be white. And it's really interesting to look at because you notice things differently. So sometimes you might see that as just a way to get a different view, so to speak. But for the most part, you're gonna see them like this. But I think it's the slide that I have that shows you the anterior ribs versus posterior is done like that, so you'll see it. When I first saw it, I'm like, wait, what? Like, what's wrong with this picture? And it took me a minute to think, everything's reversed. But it does give you a different view. It's kind of cool. So your four densities: bone, water, fat, and air. Bone is the most dense, it's going to look more white. Air is the least dense, most radiolucent, it's gonna appear black, okay? Now let's talk a little bit about the most common views, the radiographic views. Most of the time, the x-rays that you see will be posterior anterior, PA. This means, remember that imaging cassette that I showed you on the back? This one right here where the film cassette is. How many of you have had x-rays? You know how you stand against the plate? Okay, that's the cassette, okay? In a PA x-ray, that cassette is actually placed on the anterior portion. So the x-ray, the beams themselves are coming posterior to anterior, and the image is captured on the chest. That plate or that cassette is on the anterior portion. Another one that you will commonly see is lateral beam. And this, of course, is taken from the side. And generally, the beam is projected from the patient's right side through to their left side. So their left side will be against that plate, okay? And the x-rays come this way. We're going to talk about each of these special views in just a minute, and we're going to compare the PA view to the AP view. So here's just a general, whoops, sorry, I hit another button. Here's a view of the lateral image. And the benefits of this is that here's the heart right here. You can see the aorta up here. You can actually see the diaphragm, and you can see behind the heart and even behind the sternum. So if you took an x-ray that was coming from this way and you had just the standard, chest x-ray, you really can't see behind a lot of those bony structures. But turning to the side allows you to see up behind these things. So depending on what you're looking for, this may be a benefit to you. It's usually done with the left side against the plate, like I mentioned, so the x-rays are coming from the right to the left to have less magnification of the heart. Because if it's done the other way, sometimes the heart can look bigger. Okay? You can also see some of the pulmonary vessels here. All right, so that's a lateral view. Now, one of the special views is called lateral decubitus, LD. I want you to think of it being lying down, because that's what the patient's doing, okay? You can see that this is done to assess whether there is pleural effusion in the chest. Pleural effusion is that fluid that's in what part of the chest? Where does it reside? For pleural effusions, is it in the lungs or is it in the chest wall outside the lungs? Outside the lungs. So it's gonna sort of be free floating, if you will. It can also be done, jump down here to find the presence of a pneumothorax. So thinking about how gravity works, what does fluid or water do when gravity is present? Does it go down or go up? Down. What about air? Is air gonna go up or go down? Up. So that's important to remember. That's why this type of positioning is used. Air tends to rise, fluid tends to fall. So if you suspect that a patient has a pleural effusion, you're going to place them on the affected side. So let's say you have the patient sitting up and you're doing your assessment and you notice that on the right side, about midway down the thoracic wall or midway down the lung field, you start to hear less breath sounds, and you start to recognize this sounds a little flat when I percuss it, and I'm feeling more vibration when I do my tactile fremetus right in this lower section. And you might think this could be fluid outside of the pleural, outside the lung. Actually, when it's outside, your tactile fremetus will not be increased. Anybody remember why? It'll be decreased because that's putting more space between, so it'll be decreased fremetus. You would have them lay on their left side for this x-ray, because when they lay, you'll be able to see if there's water, the water shifts down this way. You could certainly do an upright PA, and you'll see water kind of in the right side of the lung like this, but then when you lay them down, that water will move, and it'll be accumulating down along the lateral part of their wall, their chest wall, okay? So you're kind of seeing if this is free-flowing fluid, it's going to be a pleural effusion. As far as a pneumothorax, you want to position the patient on the opposite side of where you think they might have the pneumothorax. So let's use this example. Patient comes in, they're very short of breath, they're a little cyanotic, they're having a lot of trouble breathing. You do your assessment and find that on the left side, there's a section where you don't hear much breath sounds, you don't feel much of your tactile fremetus, you don't see a lot of excursion, and you're thinking this could be a pneumothorax on the left. You would lay them on the right, because that air that might be here, and when you lay them down, it's going to go to the top portion of their lung field, because that air will rise. So it's kind of giving it a chance to move around, to rule out other things and say, yep, that's air in the chest wall because it's moving around. That's not like loculated or it's fixed in place. Does that make sense? The thing that I want you to remember is if you're wanting to diagnose either a pneumothorax or a pleural effusion, what's the best position? What kind of x-ray are you going to get? A lateral decubitus view. Or if I flip it around and say the lateral decubitus view is best used to diagnose what conditions, you're going to say pleural effusion or pneumothorax. Okay? In this particular x-ray, they're saying that the posterior anterior radiograph in a lateral decubitus position, you're able to see this pneumothorax up here, and they also say pleural effusion here. So what they mean by this is that when I said a regular PA, they're always with the patient upright. This is saying they're doing a PA radiograph, so the plate is in the front, the beams are coming from the back, but their position has changed and they're lying down. That's what that means. Any questions about lateral decubitus? What can it be used to diagnose? Pleural effusion and a pneumothorax. Okay, good. Then we have a view called an apical lordotic view. I don't know that we see this too much, but you can see how the patient's standing, and more importantly, you can see how the x-ray beams are coming up here. So this is kind of going up under the top portion of the lungs. It's a view sort of coming from this way, so it's able to look closer at the middle lobe or even the top of the lungs, okay? And it's all, the patient standing upright. The x-ray is coming from anterior to posterior here, and they're angled up this way, kind of looking up under. And the interesting thing is, in a normal x-ray, you see the clavicles, but in this one you don't, because it's kind of getting that view up under the clavicles. So if you were suspecting that the clavicles or something else was obscuring your view, changing the angle of those x-rays can help you see up and under those. That's called the apical lordotic view. And then we have the oblique view. Actually, I had an x-ray just like this when I was diagnosed with pneumonia. They had me do this view. So it's going to separate, again, let you see pulmonary or even mediastinal things from things that might overlap it with the regular just straight on x-ray. Okay, so it's kind of getting that side. You can see how the patient is standing, arm raised up the plate, so it's going to come from this way through or this way through, and they're not they're at a 45-degree angle, so they're not standing straight up against something, they're sort of rotated a little bit. either way, depending on the area that they're wanting to see. But again, this is a different view, just to get up behind some of those other things. Mainly to look at mediastinal or pulmonary lesions. If things like the heart or other kind of infiltrates may be blocking them, getting that view lets you look at those a little bit more carefully. So all of these, the oblique view, the apical lordotic, and even the lateral decubitus, they're sort of special positions if you're thinking there's something particular going on. Typically, the standard x-ray is going to be just that PA straight on picture. And that's what we're going to spend most of our time looking at. When a patient has a regular x-ray, they usually have the patient in full inhalation. So they'll tell the patient to take a deep breath and hold it, because they can kind of see more of the lung fields that way. But sometimes there's benefit in doing this expiratory view. Well, they'll have the patient exhale, and then they'll take the picture. And this is a good example of this. So this is an expiratory view x-ray on the left. The one on the right is the regular one where they would have taken an increase, an inhalation. And you can tell because you can see the diaphragm is flattened here. It's normal to have the right side higher than the left, but see the difference between the diaphragm here versus the diaphragm on the expiratory view? Can you tell the difference? That's one way you can recognize it's expiratory if you didn't look at the way it was labeled. So what we're looking at, it's saying that in this view, they were able to detect a small pneumothorax that wasn't readily seen in the typical inspired PA x-ray. So there's actually a pneumothorax up here, and it's really subtle and difficult to see. But when the patient exhales, it allows that pneumothorax to take up more space because there's less air in the lungs. So now you can see it pretty distinctly here. And one of the ways to pick up on a pneumothorax, especially when it's not like full or really retention pneumothorax, it's pretty dramatic, is you see all this kind of wispy light, kind of wispy white through here. Those are all different kinds of vascular markings and just kind of lung tissue. But notice up here, you don't have any of that. There's an absence of all that thin tissue or vascular markings. So that's one of the things you can look for when you're looking for a pneumothorax, is it's just black. You see the ribs, but it's black because there's a small pneumothorax in the upper left lobe here. It's still here on this one, but this is a full inhalation and it's harder to see. So that's where an expiratory view x-ray may be able to pick up on things that you don't normally see in a full inhalation x-ray. Okay, can everybody see the difference? This little pneumothorax here, how it's just black in the ribs without all this extra radiolucent tissue. So I mentioned that posterior to anterior is the most common. There is obviously anterior to posterior. And this is just the reverse. The cassette is placed behind the patient and the x-rays come through the anterior first to the back. Can you think of where patients might be where this is more common? So if I'm gonna get an x-ray, I'm gonna walk into the imaging department and they're gonna have me stand up, with the cassette behind me. This cassette in front of me, so I'll be like this. And they're gonna send the beams posterior to anterior. And they'll have me, turn whatever. When would patients be more likely to have an anterior posterior where the plates behind them and the x-rays are coming from the front? If they can't stand, if they're in a bed, such as a bed where they can't just get up and do things like we do, or maybe they're hooked to other machines, where would that be?
ER.
ER and
ICU.
ICU, yeah. This is usually the kind of x-rays that they'll get. So if they're more portable x-rays. They bring in their big x-ray machine and they slide that under and they do it. You can see that the portables are the same indications: evaluate lung status, evaluate placement of lines and tubes, see the results of invasive procedures. The key is that the plate is put behind the back and the beams come this way. And because of the equipment, you often lose that recommended 6 feet distance. It's often closer to 4 feet. So we can see some distortion, mainly in the magnification, and the heart will look a little more enlarged. So it's important that if you see what you would think would be an enlarged heart, which I'll show you how to determine that, to realize, oh, this is an AP film, not a PA film. And that word film is still used. Now everything's digital, you can pull it up on your computer, but you've seen the films that we have in the lab, the actual films themselves, so people often still use that term, even though we don't have physical films like we used to as much, now that they're all digitized and you can just pull them up on your screen. But it would be important to recognize that you have an AP film, because there's certain things that will look different because of some of the compromise. Another issue that we run into is the patient's positioning, being that they're maybe in the ER, they're in the ICUs, they may not be positioned the best, so you may have some rotation that would block off certain parts of what you're trying to see. Not ideal, but in those situations, that's what you have, so you work with it. So recognizing, again, a PA view from an AP view would be beneficial.
Do they put that on the x-ray?
It should be on the x-ray, yes, you should be able to see that. And one of the things when I was learning x-rays, which I didn't learn much about x-rays in respiratory school, I kind of picked it up later, is I would take an x-ray and I'd look and I'm like, wait, that's backwards. Nope, that's backwards. No, and just, something that simple, and you guys will be able to do that, and I'll tell you some tips to learn to do that too. And in those, they're written down on the bottom. Sometimes they've been cut off because we got rid of all the personal identifiers, so sometimes that got cut off too. And we're like, we think this is an AP, not a PA. But yes, and the way they are now, you would know that, okay? And if you start reading, I would encourage every one of you on your next clinical, get your preceptor to pull up somebody's x-ray. The x-ray interpretations are very vague. Let's say you're looking for, give me something. What do you want to look for? A disease, huh? A disease. COPD. Okay. So they might say things like, diffuse infiltrates noted in this section and some hyperinflation noting, possibly indicating da 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 da. They're not going to say, oh, this is your emphysema patient. Yep, that's emphysema. They don't say that. Or if there's a consolidation, you think somebody has pneumonia, they'll say consolidation seen in the lower left lobe of the lung with blah blah blah, consistent with, and they'll list 5 or 6 things because they're just reading the x-ray. It's up to the clinician, or maybe you all in nursing, everyone working together to say, here's what we found on our assessment, here's what the labs say, here's what this says, and putting all that together to say, oh, this consolidation could, yep, that confirms our cancer, our tumor diagnosis. Oh yeah, that confirms our pneumonia diagnosis, or whatever, okay? But the x-rays, I kind of get a kick that they're just so vague, but that's their job. They're not there to diagnose, they're there to read the x-ray and to help you take that tool and apply it to what you see and how your patients present. Okay, AP view, usually the portable x-rays, usually a little distorted with the cardiac magnification especially, so magnification, maybe not the best positioning because they're done in ICUs, ERs, where the patient just can't. Often they're not in full inhalation either because they can't follow those commands. Okay. So here's kind of both of them together. Here's your PA. Okay, I'll say the gold standard. That's just my term, that's not anything official. And then this is the AP, the more portable one. So you see here a couple things. See how you can see these you can see the clavicles here. Look at the clavicles on this one. See how this one's a little shorter than this side? That's indicating that the positioning wasn't quite great, okay? You can also see this little thing that looks like kind of like a bat, this dark bat wing. That's a shadow from the scapula. That you don't have that on the PA. And then we look at the heart. The heart, sometimes this is called a cardiac shadow. I always say the heart. I guess cardiac shadow is probably more accurate. But see the heart here, the size of the heart? Look at it over here. There's some magnification that goes on with that. So that's kind of comparing them and let you see kind of what some of the differences are there. Can you guys see it? Okay. Evaluating what you see. So the first thing we're going to talk about is, well, I shouldn't say the first thing because I kind of put them all together. we're gonna look at recognizing anatomic landmarks. That's what you're going to have to do on your test. So it's important to put some time into studying those. Review clinical findings before you look at an x-ray is always helpful because it's kind of leading you down to what you might see, but you still need to look at the whole x-ray, not just zero in on, is there that consolidation in the right lower lobe? Okay, don't make any rash judgments, look at the whole thing. And then the placing of the chest film. Remember, this is the patient like they're looking at me, right? So if I see something here, is that the patient's right or left? Turn around, it's the patient's left. So it's kind of mirrored image to you, okay? This is the left of the patient, this is the right. Okay, so always remember what side you're looking at. And really looking at the heart is one of the ways that I do that. The heart usually sits toward the left, right? So I wanna make sure that my heart is positioned this way. So if I have it backwards, I can pick that up pretty quickly that, oh no, I've got this wrong. Flip it around. You will also see that the right hemidiaphragm, this is the diaphragm, the right side is generally higher. That's a normal finding. So that's another way that you can tell. And it tells you cardiac shadow more prominent on the left side, which is what I just told you. So this is an image that shows you where they've actually drawn on there. We're gonna look at one that's not so drawn, so you can kind of see what it looks like in real life. But one of the first things you can pick up is the trachea. The trachea, will it be a little, without looking at this image, think it through, will it have a little more black undertones or white undertones, the trachea? Whoops. What's in the trachea? Is it a dense object, a dense tissue? What's in the trachea? Hopefully, air. Hopefully there's not a bunch of gunk in there, but Lego blocks or something. But yeah, air. So what color would you expect that to be? What does air look like on an x-ray? Black or blackish, right? So you can pick up the trachea. This is a little whiter than what we're gonna see on the next slide. And you can usually see this bifurcation when it goes into the right and left main stem as well. What's this called, this bifurcation? What do we call that? The carina, right? You can often see the aortic arch. You can see this cardiac shadow, but I always default and say heart, so you're gonna hear me say that. Above the heart, we see like a knob, and that's the aortic arch. This fluffy stuff here, let me go back to this x-ray. See these fluffy infiltrates here? Those are your hyla, the right and left hyla. And that's just where the blood vessels enter and exit the heart. Okay, we call that the hilum collectively. Excuse me, you see the heart. You can also usually see the spinal processes through the trachea and even down behind that cardiac shadow. You can see the spine. Costophrenic angles, you guys are familiar with those? The outer edges or the lateral edges of the lungs that kind of come down to a point. And then we have the diaphragm. Notice in this one, you can also tell what gender it is because we do see breast shadow here. So you know this is a female versus a male. And these are some of the main things that we're gonna pick up on. You also notice the scapula, the clavicles here. And of course, the ribs. Are these anterior or posterior ribs? Remember what I told you? The ones that you see very clearly, what are those? Anterior or posterior? Posterior, good. Now here's more of an x-ray without everything drawn. And you can see the same thing. See how you can see the trachea is darker? And if it comes down, you can see it bifurcate. Sometimes that carina is a little hard to see on some x-rays. But it branches off, darn it. It branches off right here to the right and left main stem. Here's your cart or your cardiac shadow. And then up here, this little bulge, that's your aortic arch, or that they call it, some call it an aortic knob. You have the left hilum here, the right hilum here. Remember, that's just where the vessels are entering and exiting the lungs and the heart, from the lungs to the heart. They've even labeled the right and left atrium for you. When you see the spine through the trachea, these little round things, those are it's like the back of the vertebrae. Those are the spinal or spinous processes. And when they're lined up nice like that, that usually means the patient is centered. If that's in one indication of a good position. See your clavicles, and we can see all the clavicles, and they're equal on both sides. Another indication that the patient's in good position. We have our diaphragm here and here. What's each half of that called? And when we're just looking at half of it, what do we call it? See it labeled? Hemidiaphragm. So we have the right hemidiaphragm and the left. Again, the right side is usually higher, so that's normal. I don't worry so much about the costocardiac angles, but I do want you to know these costophrenic angles on both sides here. And then again, you can see this is a female patient. These are the types of things you should be able to label at the end of this section. But this is going to take some time to study and to review, right? Anybody have any questions about what you see on this slide? Everybody good? I don't see any. Eli's good, okay? And then this is a very similar one with things marked out of what you see laterally. First you can see the trachea, not nearly as clear here. And I even have trouble sometimes picking out some of these subtle things on a lateral x-ray. And the bifurcations here, just to give you a kind of a point of reference, this is the sternum, and then you see the spine here in the back, okay? Here's your heart, or cardiac shadow. That's your aortic notch or aortic knob up here. And then some of these numbers are just showing you pulmonary arteries and pulmonary veins and things like that, which you have to be, I think, trained more beyond what we're going to be doing to be able to pick up those pretty easily. But you do notice that you have your diaphragm, hemidiaphragm down here as well. Okay, a little harder to see with the lateral image. I'm not going to ask you to identify anything with the lateral image. Okay, I do want you to pay attention to this image. And we'll do an exercise to let you practice that. So when you interpret an x-ray, you're looking obviously at the different shades of white and black and gray to kind of evaluate the penetration. So the first thing says x-ray penetration is inversely proportional to density. So that means that the more dense it is, the more it gets absorbed, the less gets penetrated. And the less dense it is, like air, the more that passes through, so the more penetration you have. Normal lung tissue has low density. That's why we can see it, because the lungs hopefully have more air in them. When you have things like cavities or blebs where there may not be air, those can be, where they have little pockets of air rather, they can be darker, and you can see those on an x-ray. Areas of consolidation, I've mentioned pneumonia and tumor. Even collapse. What is it called when we have areas of collapsed airways? We have a name for that. Atelectasis. Those will also be more dense, so they will be a little whiter to indicate that more radiopaque. The greatest density, the most dense in the chest are those bones. So the ribs, the clavicles that you'll see. Sometimes you can see a scapula depending on your view. And then the systematic review. So this is one example. You're not going to have to know this, but this is one example. Just like we'll talk about something similar when we do ECGs. You should have kind of a method that you use to look at each x-ray, or a method that you use to look at each ECG. Just like you have a method to do for your patient assessment. You're not just willy-nilly doing it different on everybody, hopefully. Right? Oh, I see some. We did give you certain things you do for certain sections, right? Because then you don't miss anything when you follow some kind of pattern. So this is showing you a pattern. We'll talk about these different things. This one I kind of laugh. It's RIP. A, B, C, D, all the way through I. And they're looking at rotation, inspiration, penetration, meaning that are things, penetrating through areas of density will be wider. Do I notice more white? Is there more, less penetration going on? The bones, the cardiac silhouette, and so on. I'd like to go ahead and jump to this one to talk about each of those things where you can actually see a film. So I mentioned patient's position. I'm watching my time here. Some things you can look at, you see spine and medial ends of clavicles. So in this particular film, I see my trachea right here. And see where I can see this bifurcation right here. Can you guys see that on your screens? This is the bifurcation, this is the carina. And I see my spinal processes nicely right in that trachea. That's a good thing. That's an indicator of good position. My clavicles, what I see, are equal on both sides. I'm not seeing a short clavicle or a short view of a clavicle here and a big one here. So when they're equal, then that means that the patient is in a pretty good position. even a slight rotation, you know, even if they're turned a little this way, is gonna throw those clavicles off, where one might be longer than the other. So it could indicate not only how they're placed in the bed, but even slight rotation. Now let's talk a little bit about exposure, because I wanna talk to you about something being overexposed and underexposed. Look at the spine through the heart. So as you come down, this is not, I don't really like this example for this, but you should barely be able to see, you can see the vertebrae through here. This is a little hard to see on this one. You'll be able to see it. Let's look back at this other one that I showed you. Oh, this one. See how you can see the spine down through here? Barely, it's not blaring at you, but when you look for it, you can see it. This is good exposure, okay? If they're very easily seen, like, boy, they just jump out at you, and everything, the x-ray itself will probably have more black overall, almost like a blackout in places. That means that this has been overexposed, okay? If it's difficult to see, I think this is a little difficult to see, I'm straining to see it, that means that the images are underexposed and things will appear more white. And the way that I try to remember that is just underexposed is UVW white. Underexposed, things are more white. However you can remember that. So if it's overexposed, things look more black and you'll really be able to see the spine very clearly. And other things will look more black, unusually black. If it's underexposed, they're gonna have a more whitish. And then, you know, either way, you might be missing things that you wanna see. So it's important to identify that. Inspiration, if the patient takes a good big deep breath and holds it, you should be able to count at least 9 posterior ribs, sometimes between 9 and 11, okay? And we can count those here by saying 1, 2, 3, 4, 5, 6, 7, 8, 9, let's try this side, 1, 2, 3, 4, 5, 6, 7. I get about 8 on this side. So this may not be a full inhalation, but generally it's posterior ribs, 9 to 11.
I'm sorry, you said that if it's overexposed, it's more black.
I'm gonna show you a picture. Let's look here. Let's just go ahead and look at it. So see how this is exaggerated, but see how this is, everything looks really black. See how plain that spine is? And other things, it's unusually black. That's an example of very, very overexposed. Whereas this one, you really can't see anything. This is underexposed. Okay, so can you kind of get, does that help? Either one, you're not really seeing the best images. So I would say you probably want to get another one because you can miss things when you can't see. Everybody okay in that over and under exposure? You can pull up, you can Google over and under exposure. They'll show you hands or feet and they'll show all kinds of things. And you'll see this is good, this is underexposed, this is overexposed. You can look at other images than just this one. You should be able to, again, identify these things, the heart or the cardiac shadow, and look at the size. So one of the things we look at is the diameter of the heart in comparison to the diameter of the chest. Normally, when you go from edge to edge of the heart, that diameter should be less than 50% of your thoracic diameter. That would be normal. If the cardiac diameter is wider or bigger than 50%, larger than 50%, that could indicate an enlarged heart or cardiomegaly, which could be an indication of like congestive heart failure. We talked about seeing the trachea, the main stem bronchi, other bony structures. We mentioned the clavicles, we have the ribs, diaphragm. What is this right here? Here's my diaphragm, the left diaphragm and the right. What is this little darker area right here? It's an air bubble in the stomach, and that's very common. So that's kind of even a good landmark. All right, there's my air bubble. And what side's it on? It's on your right, but it's the patient's left. So this could help you in making sure, another clue that you have the x-ray turned the right way, or with the films that we have. And then these costophrenic angles that are here on the lateral edges. Okay? There's a lot of other things going on with this patient. If we measure this carefully, we might find a little bit of an enlarged heart because this looks like a lot of, very similar to what congestive heart failure looks like in the early stages of. Anybody have any questions about this slide or these images? Any questions about the exposure? And notice it says penetration. That's just, you know, the ability for the X-rays beams to go through and penetrate through to the cassette. But this, we commonly call this exposure. Underexposed and overexposed. Okay, here's one of those flip around reverse contrast things. See how the bones are darker and then the places of less density are whiter? But I think this is a good one to be able to show you the difference between posterior ribs and anterior. So the ribs that you readily see here, these are posterior, right? We've already established that. See where they've drawn the anterior ribs? Look over at this image. See how they're kind of in the background and they're coming down like this? Can you see them? The arrows are pointing to the inferior or the top edge of each rib. And they just have them numbered. Can you guys see the anterior ribs in the background? They're kind of curving down and around. So remember the difference, because I will ask you a question about whether you're looking at anterior ribs or posterior ribs, or for you to, when I give you x-rays next week, I'm hoping we can put them on the wall and you guys can, there's enough room for you guys to get in teams, and because the light will help you see them. I'm gonna ask you to point out where's the posterior ribs, where's the anterior ribs, so you can make sure you can see them. I'm gonna go ahead and hit silhouette sign and air bronchograms, and then we'll stop there. The silhouette sign, see how you have this kind of fuzzy section right here? The silhouette sign is primarily used to determine whether there's a pulmonary infiltrate that's in contact with other things in the thoracic in the chest or not, other thoracic structures. So when things are infiltrates like this that make it impossible or very difficult to see the cardiac shadow or the heart border, notice we can't see where the heart is over here because of this infiltrate here. When the infiltrate is positioned in such a way that it obliterates or keeps us from seeing the outer borders of the heart, then it's located in the anterior as opposed to a posterior section of the lungs, okay? So it may mean that it's not so intrapulmonary, but more of an anterior thing that you need to check for. And that's called a silhouette sign, just indicating what, and that may rule out things like intrapulmonary disease and get you looking at something else. This is a neat one. This is called an air bronchogram. And you see it, this little black line right through here. You can best see these air bronchograms usually when there's a consolidated area, but there's an open or patent bronchiole in the middle of it. And that's what we're seeing here. This is kind of some consolidation or some secretions through here, and then you can clearly see that open airway, which is called, this is called an air bronchogram. Visible bronchi when surrounded by consolidated alveoli. This confirms intrapulmonary disease because our bronchioles and alveoli, they're inside the lungs, right? So things like pneumonia, bronchitis, those are intrapulmonary. This confirms things like that. And that is called an air bronchogram. When you look at other pneumonia images, you can see sometimes several air bronchograms. So this is a silhouette sign. Something is more, it's kind of touching or around the border of the heart anteriorly. This is an air bronchogram indicating intra-disease or intra-issues of the lungs, okay? And I think we're gonna stop there. We'll pick up Tuesday, because we're gonna start looking at some of these things. Does anybody have any questions about what